So I run the Parkinson Center at UCSF. We are a center of excellence and have been one since 1992, actually. I know a lot of information about that because we actually just finished our accreditation site visit, which happens every 5 years. So I probably am more versed in that knowledge right now than I probably have been. So we're going to give 2 talks today. All of this information, for the most part, was coalesced because we got a grant actually from the Parkinson's Foundation as a result of one of the Moving Day grants, the community grants, a few years ago. And we had seen that there was a place that needed to be filled for caregivers. That a lot of caregivers go into appointments with the patient and all the questions get answered for the patient, but the caregiver never really has time because, let's face it, in a follow-up clinic appointment you have 20 minutes maybe, usually a laundry list of things you have to get through, medication changes, all the rest. And we just recognized that there was a lot of questions that were left unanswered by the caregivers. And so we brought together a bunch of caregivers and we said, what are things that you want to know more about? What are the things that concern you? And we basically developed 6 talks based on this group that we then took out to caregiver support groups in the Bay Area and started presenting both as a series or as one-offs, depending on, some support groups, they say, well, we like having guest speakers, but we only meet once a month, and it's really important for us to actually also talk and serve what a caregiver support group is supposed to do. And, maybe you can come this month and then maybe at the end of the year, but we can't give up that time. It's become really precious for us. So it was a really great experience, but I just want to acknowledge that that did come about because of the Community Moving Day grant. So the money that's raised by Moving Days, it's really great to actually see that go directly back into the community to serve programs such as this. So talk to Bernice if you want to know more about Moving Day. So first we're going to talk about cognitive changes and communication challenges. So obviously everyone here is probably really well versed in some of the physical communication challenges that come about because of Parkinson's. So Parkinson's does affect the voice. People can become really soft or hoarse. It's basically because the vocal cords and the muscles of the throat have become more rigid. And as well, there's a reduction in facial expression, what they call hypomania. This also is due to the muscle rigidity. This sometimes, and we'll talk about this a little later as well, this sometimes gives the appearance of the person not understanding, that they are, you're sort of talking to them and you don't really see that they are understanding what you're saying. And what that is basically that we as humans take so many nonverbal cues when we have conversations with people. It's the eyelids, close a little bit, and the muscle, changes a little bit in the cheeks. And all of these are signs that basically that we give to someone we're talking to that indicate that we're involved, right? And with Parkinson's, a lot of those muscles just become a little more rigid, and so you're not seeing that sort of viability in people's faces. And a lot of times we then take that as they're not understanding me. They're understanding you perfectly. They just aren't able to now give you all those little clues that we give in nonverbal communication. So body language as well, that kind of goes along with it too. There's just less spontaneity. And as well, if someone is experiencing dyskinesias, which is basically, too much cinnamon, and they start to get these kinds of movements, that also can interfere then with those sort of nonverbal things that we're seeing. And then hearing difficulty, obviously this is something that just becomes more rampant, unfortunately, as we age. But if you add it with all of these other little complications, it's just something that needs to be gotten on top of and dealt with sooner rather than later, because you want to have as many, obviously, tools as possible. And then handwriting, this is sometimes one of the first things that people notice before they're actually diagnosed, is that their handwriting becomes smaller, it becomes cramped. How many of us really do a lot of handwriting anymore? Okay, but that it can also affect people's ability to work on phones or to type, to mouse, things like that. So these are all just the real physical communication aspects. So I was telling Sarah, I was gifted a bundle of 16 journals a few years ago from the daughter of a man who had Parkinson's. And he had basically asked his wife to chronicle his day-to-day activities and basically he was a scientist, and he wanted her to sort of document his journey with this disease. And so I ended up sitting on Bart every day, with a highlighter, basically going through, and it was really amazing because it was literally every single day that she wrote for 6.5 years what she did on a daily basis, the problems that he experienced, the problems that she experienced, and it really just is it's a gold mine of all the things that I think that hopefully you guys will really recognize as things that caregivers do see and experience a lot. So 1990, obviously, we're going back almost 30 years now. So John Doe, he was on a relatively low amount of Cinemet, and Elavil, which is an early SSRI, Selegiline, which was before Azilect, basically, it was the other MAOB inhibitor. Metamucil, he was chronically constipated. There are pages and pages about constipation in this journal. And then a whole host of other medications that he took, PRN, a lot of which we would say people should not be taking, especially if they're over the age of 65, but definitely not when they are also taking all these other medications. So things like Valium, Mellaril, Orfedrine, which, so this man actually had polio when he was younger, and so he developed a lot of back problems as he got older. But a lot of these are sort of heavy-duty drugs that you really wouldn't want to give to somebody, certainly on a regular basis. Classic symptoms, the tremor, stiffness, slowness, depression, which probably might have been his biggest problem, and it was completely untreated. He was in complete denial about it. I actually was able to meet with the family, and they talked about a historical familial problem with depression, and I think that if his depression had been treated properly, a lot of his issues actually would have been lessened a lot. Constipation and bladder issues, as I said, gait balance, daytime somnolence. So I want to introduce this. We'll see this a lot more in actually the second talk, but just wanted to let you know. So here's an excerpt from the journal. We both look for hidden meanings in what the other say and does. John is argumentative and unreceptive to suggestions. He'll say, well, what do you want me to do? And then when I say go to bed and lie down, he'll present arguments. Well, you always say, so now you're a doctor. John mumbles incoherently. He says things sotto voce, uses made-up words, can't find the right word to use. He gets so frustrated when I ask to repeat himself, and he tells me that I'm not paying attention to him, and that obviously I'm not qualified enough to discuss. It gets so bad that I have to stop asking for more clarification, since it just gets him more angry, right? So right there, I think, is the quintessential Parkinson's conversation issue, right? Which is, people don't always realize that their voice isn't as loud as it used to be. And if you don't hear it for whatever, we're all getting old, our hearing is not as great as it used to be either. If we ask someone to repeat themselves and then we have to ask them to repeat themselves again, that instantly builds up a lot of frustration of this person's not paying attention to me versus, I'm sorry, I literally just cannot hear what you're saying. But that's a terrible way to start any conversation if it's already moving from a point of frustration about whether or not you're being heard. So communication challenges for the person with Parkinson's. The most important thing to do is to get a speech pathologist evaluation. Most big medical centers are going to have one. Hopefully, if it's a movement disorder clinic, they might actually have someone in the clinic that can come in and just do a quick evaluation. If not, it's a very easy referral to write. So the main thing is LSVT, stands for the Lee-Silverman Vocal Technique. This is basically a very intense speech therapy program. It goes for about a month, but it's every day for a month, or 5 days a week for a month. But it really shows a lot of benefits for 2 and 3 years down the road. And people joke about it being yelling therapy, that basically you're teaching people how to yell. And it's not that. It's teaching people how to speak from their diaphragm and to create more volume by using the muscles down here rather than trying to rely where everyone used to just sort of speak from here, that you actually need to use more lung capacity. And also an auditory function test, as I said, we all are losing our hearing slowly but surely. So for care partners, caregivers, making sure to face the person when they're talking is one of the easiest ways. To decrease background noise. And again, these are all things that for anyone as we get older and our hearing is not as acute are more important. And don't rely on facial expressions, as I said, just because it can give this mask of not understanding when in fact it really, and then just being patient, allowing the patient or the person to express themselves. We all get impatient as well, and we want to hurry the conversation along, or it's not moving at the speed that we want it to. But it really is important to make sure that the person is allowed the space to speak for themselves. And it lends to the sort of remaining independent, which is really important for anyone with Parkinson's. They should be doing everything for themselves that they can, because if you start helping, then they are going to lose the ability to do those things. So it really is important to stay as independent as possible for as long as possible, okay? And that includes things like buttoning buttons, zipping zippers, tying shoes, all that kind of stuff that we, of course, are all going to be chronically late, and it's, all right, well, we got to get out the door, and the person's sitting there, and that damn left cut button just doesn't seem to work, and it's just like, okay, let me just do it so we can go. And what you want to think about is that those sorts of things are actually sort of mini physical therapy or occupational therapy, right? That getting that button and doing it and taking the time to get it done for the person means that tomorrow it's going to be a little easier to do it. And the day after that, it's actually going to be even easier. Whereas conversely, if they get helped, the next day it's going to be harder for them to do, and it's going to gradually get to the point that they're no longer going to be able to do it for themselves. So a little bit more about LSVT. So as I said, it is very effective for Parkinson's. It's been studied by several different institutions, including the NIH, and it's shown that it is scientifically very helpful and valid. So it trains people with Parkinson's to use their voice at what would be a normal loudness level when speaking at home. And the key to the treatment is that it's recalibrating what the person thinks that they are speaking in normal volume to actually get them to a volume that is normal for all the rest of us, and make them also feel comfortable with using that level of a voice. It does so basically by three modes: the target, so the loudness or the amplitude, the mode, so that it's very intensive, and high effort. So this does have the thing that all of us fear when we go to physical therapy, which is they give you the exercises to do at home. And we're all really great when a physical therapist is there forcing us to do everything. And then the second we go home with the exercise, so it basically forces people to do this every single day, as well as doing the things at home. And then, the recalibration of basically feeling comfortable again with the fact that they are using a louder voice. The great part about LSVT, it is sort of set as the gold standard for speech therapy for Parkinson's, and it has shown definite improvements in variation and loudness, and that it actually is seen for 2 years plus as far as post-treatment. So it's actually long-lasting, which is the best part about it. As well as secondary improvements that you also can see are better articulation, changes in swallowing, which is really important as far as the safety thing is concerned, improved facial expressions, because when you are working all of these muscles, you're also working all of these muscles, and making them more pliable and using them more often is really going to be better in the long run. And then possible speech-related brain changes, so neuroplasticity and this sort of buzzwords that we hear a lot of these days, that doing these sorts of exercises might actually really be of improvement to our brain function. So that's just sort of the quick and dirty on speech-related, communication-related issues. So cognitive changes, bit more difficult, obviously, to deal with, not as easy to just do a therapy or something along those lines. So people with Parkinson's, we say roughly 25 to 40% will exhibit some sort of clinical cognitive change. Most talk about MCI, or mild cognitive impairment, which is basically the thing that falls between normal aging-related stuff and dementia, which is just more serious cognitive changes. And anyone over the age of 85 is just more likely to experience dementia. And that just basically is cognitive impairment that affects more aspects of the person. So what are the causes? It can be attributed to the disease itself. That basically the more we know about Parkinson's is we know it's not just a movement disorder, but it's actually affecting several different parts of the brain. but that it also might actually be a result of preventable or reversible causes. So we'll talk about that in a second. This is just, sort of a slice of a brain. Basically, the person on the left had Parkinson's, the person on the right is a control. So we talk about the substantia nigra, which is where we often will see Parkinson's-related pathology when we do autopsies. So substantia nigra is basically, I think, Latin for the black substance. And you can see on the right, that's right, this sort of black lines on either side. And then on the one on the left, those black areas are just much lighter. And that basically represents neuronal death. So the black area, it means that it's full of these dopaminergic neurons, and the one on the left shows a person with Parkinson's where these neurons have died. So what we think, that the neurons actually, we know that the frontal cortex is related to attention and planning and what they call the executive functions. And the loss of these neurons disrupts the communication with the brain. Lewy bodies, which is sort of the term that a lot of people use, or Lewy body pathology, is what we always find when we do an autopsy of a person who had Parkinson's. It's actually the only way of really confirming that a person had true Parkinson's, is that we find these Lewy body pathologies. It's basically clumping of proteins of alpha-synuclein. They talk about a lot of the other proteins related to maybe Alzheimer's with the tau, and then the one that a lot of the NFL players are having. It's again these just sort of clumping of these proteins that shouldn't be there, but it is certainly the only way that we really identify that a person truly did have Parkinson's. So some of the risk factors, sorry to say for all the men in the room, but being male, you are more likely to experience some cognitive change. Older age and onset as well. The thought there being that, because of the normal aging process, in addition to the fact that the Parkinson's might be affecting the brain. Again, the disease progression, so more severe symptoms. And then, having concurrent mood disturbances or sleep disturbances, REM sleep behavior disorder being the big one. So basically people that fight and kick in their sleep. This is something that a person is totally unaware about, but you as caregivers should certainly know about it and also be careful, that you're taking the proper precautions to make sure that you're safe, because there certainly are people who punch and kick a spouse, that roll out of bed, that break a lamp next to the bed, that kind of thing. And then there are just some genetic and family histories that can go along that can contribute. So some of the areas that are affected by Parkinson's, so again, memory, so short-term learning as well as learning new information. Executive function, which is where we most often see disruption with Parkinson's. So planning, organizing, scheduling, shifting attention, filtering. It's often said that, people with Parkinson's, you shouldn't give them, a lot of choices, especially as cognitive change really, you shouldn't say, okay, here's 6 different things, each which has several subcategories, make a decision and that's just, it becomes more and more difficult for a person with Parkinson's to do that kind of stuff, as well as multitasking. So bradyphrenia, which is just a fancy word for slower thinking. Language, so getting harder and harder to retain names. And then visual spatial processing. Most often we see a problem with people being able to parallel park, which is an odd thing, but it is something that comes up and sometimes is sort of the first sign that people say, oh, well, he's still driving, but, he just has trouble in, parking in tight garages or parallel parking, and it's like, okay, well, that's so here's some of the possible causes, just in general for all of us, of cognitive change. So normal aging, as we said. Depression certainly is probably one of the biggest things. Sleep disturbances as well. Any of us that's not getting enough sleep, our cognition is certainly going to be affected. Fatigue as well, which obviously sort of just carries over from the sleep. Neurogenic orthostatic hypotension, which is a fancy word for low blood pressure. That basically people who have chronic low blood pressure, and neurogenic means that it's actually as a result of a disease rather than just, if someone is overheating or dehydrated, something like that. Thyroid dysfunction can certainly affect people's cognition, as well as low vitamin B12. Diabetes as well. and other autoimmunes. Infections, that's probably the most common thing that we see, for people who have a really quick cognitive change, and the great thing about that is that infections obviously can be treated. Medications and medication side effects is also that's probably the second most common, and then just biology, as we talked about. Now, of all these, the ones in red are actually treatable causes of cognitive changes. So if the person with Parkinson's is experiencing any sort of cognitive change, especially if it's coming on quicker than one would expect, then all of these things are things to really examine, before going into the sort of decision of like, okay, is this person actually experiencing some sort of mild cognitive impairment? Is to make sure that all of these things can be ruled out first. And as I said, the great thing about all of these is that they are actually treatable. So again, just underscoring the point that any sudden change indicates an acute illness. It is not Parkinson's if within 2 days a person goes from relatively normal to some sort of cognitive impairment. Most likely it's an infection. Even more likely it's probably some sort of either kidney infection or urinary tract infection, which become much more common with all of us as we get older as well, but they also can come on fairly benign, and the infection can get pretty bad before actual symptoms show up. But any cognitive change that's sudden or sharp, definitely you should be going to see the neurologist if possible, but more importantly just any physician, and getting treated most likely for some sort of infection. So some of the signs of mild cognitive impairment that we've talked about already, it's a difficulty finding words. That's one that we hear a lot. Misnaming objects, or trying, struggling to come up with the name of the object. Misplacing or losing things. Feeling overwhelmed by choices. Again, that's just sort of the thing that I think we hear a lot. Feeling easy distracted and or just some sort of delayed reaction to information, using less complex sentences, and the need for more repetition. And again, these are the sorts of things that also, a hearing test should also be, just make sure that that's in there somewhere, because for things like conversations, that's obviously something you want to make sure to investigate as well. So how do we diagnose cognitive impairment? Most likely it's you guys that are the ones that are noticing it first. Patients sometimes will put forth that information. Sometimes they don't really want to talk about it, but it's something that needs to be talked about. And you guys are all probably the best sources of information. You're seeing the patient on a daily basis, and are able to really give probably the most valid input. There are some very quick cognitive exams that can be done in a clinic. The MOCA, which is probably the best for people with Parkinson's because it actually asks questions related to the issues that people with Parkinson's most likely are experiencing with regards to cognitive impairment. The MMSE, which is the mini mental state examination, is a more broad scope of mental acuity test. But either one can be done in 10 minutes. And then there are neuropsychological workups, specialists such as neuropsychologists. This becomes more of an issue as people start to talk about deep brain stimulation, and anyone who is being considered for DBS has to basically undergo a complete evaluation with a neuropsychologist, because if people are experiencing some sort of mental or cognitive impairment pre-DBS, then the chances are that they're actually going to experience more so post-surgery. So you really want to evaluate those people very carefully to make sure that they are indeed good candidates. So we talked about some of the treatments for cognitive impairment, so addressing the underlying causes. The other thing is basically looking at the medications. As I showed you on that journal slide, there are a lot of medications that people can take, and obviously you guys probably know more than anybody about the fact that, if you're just taking handfuls of pills every day because of, high cholesterol and high blood pressure, in addition to Parkinson's, in addition to, all the other things, then it really needs to be evaluated on a semi-regular basis to make sure that there aren't medications that are combating with each other, or that, we all just become much more sensitive to medications as we get older, regardless of whether we have Parkinson's or not. So, a dosage that we took as a 50-year-old that we then take as a 70-year-old can actually have possibly more side effects or affect us very differently. And that's just part of aging, is that we just become much more susceptible to side effects, but also the medication is stronger for us. So anticholinergics, which are very old medications, or amantadine, these are drugs that basically were sort of grandfathered in before carbidopa-levodopa became available. And there are newer versions of all this stuff. The anticholinergics, not so much, but I know amantadine does. And adjusting Parkinson's medications, so trying to get the biggest sort of on time, as they talk of. Stimulants. So at one point, doctors thought it might be a good idea to give Parkinson's patients speed, with the idea that it might help with the fatigue that a lot of people complain about. This sort of fatigue that doesn't seem to be depression related, but it really is something that we hear from a lot of patients, that they just feel this apathy and this fatigue that never quite goes away. And so at one point, doctors thought, well, maybe we can give them some speed and that'll help. Turns out that's not a good idea. And then for dementia, so Exelon or rivastigmine is a drug that actually is specifically marketed for Parkinson's disease-related dementia. There also is Aricept, which is actually more focused for people with Alzheimer's, but does also get used for people with Parkinson's. And again, just using strategies to navigate some of these issues as they come up, and promoting neuroplasticity, again, this sort of fancy buzzword, which basically means that you are trying to do things to keep your brain healthy and or to actually grow new connections within the brain. And we'll talk about some of the ways we can do that. What we see most often, neuroplasticity, or why we think that it actually does exist, is when we study people who have had strokes. So they talk about forced use in strokes. So usually when a person has a stroke, one side of their body will become very weak, and hard to use. And what doctors will do is they will sort of clamp down the side that was unaffected and force the person to actually use the limb that has been affected by the stroke. And how that actually works somehow in the brain is that it just starts forcing the brain to use a new connection, or to develop a new connection to get that limb to do what it needs to do. And so we think that we might be able to actually transfer that into Parkinson's in the way that we can encourage exercise, we can encourage independence, we can encourage all of these things, keeping cognitively intact, and hopefully just retain more and more of the health of the brain. So physical and mental exercise, stress management and healthy diet, which obviously all of us should be doing anyway, but for people with Parkinson's, it's actually much more important that those sorts of things do get followed, because the idea is that we might actually be promoting better brain health through that. So activity and exercise is obviously the big one. So aerobic exercise in particular, and it doesn't have to be CrossFit, it doesn't have to be PX90, it's walking for like 30 minutes a day, right? Like that's really the baseline. It should be more than that if possible, but everyone should be walking at least 30 minutes a day. We've seen also that it does improve the cognitive function, that regular exercise. In addition, it helps with depression, especially if you're walking outside in the sunshine. All of those things actually promote much better mental health. Motor fitness and coordination, so that's mostly related to balance exercises, works with a physical therapist, but that actually can increase the volume of the basal ganglia, which is the area of the brain that's most likely affected. And as I said, it also can help depression, fatigue, and sleep disruptions. Cognitive training that we've seen, so this is things like doing crossword puzzles and Sudoku and all these sort of mental challenging things that we like to do. We do see an improvement in people with Parkinson's as related to just sort of their overall cognition. Processing speed, the main thing that you have to be careful about with crossword puzzles or any of these sorts of things is monitoring for compulsive interaction. So this mostly happens related to the dopamine agonists, which are the Mirapex and a couple other ones. And they basically cause this dopamine dysregulation syndrome where people start to become really impulsive or really compulsive with things. Dopamine is a pleasure neurotransmitter, and it basically just kind of gets locked into this loop. And so people, without realizing it, can start to spend thousands of dollars shopping online. They can become addicted to pornography. They can start having affairs. There's all these sorts of things that can come up. Any of us know that we don't check our credit card every single day usually, and in 1 month someone can rack up thousands of dollars worth of online charges before it's sort of realized that there's an issue. In the same way, one of the early signs is people start to do things compulsively, like crossword puzzles, where it's not they do a crossword puzzle a day, it's that they do 4 crossword puzzles a day, or they can't move on to doing something else until they've finished the crossword puzzle. And it's all those little signs that you can start to realize, okay, maybe there's something that's starting to build here, and stop it early. So some of the cognitive changes that for caregivers that might be helped is medication dispensers, alarms, or scheduling apps. Making sure that people are taking their medication on time. When patients really need Sinemet, they don't often forget their dosages, I think, because they realize that their next dose is coming up, because they start to feel, that the medication is wearing off, or, that if they want to continue to do whatever it is they're doing during the day. But I think it is important to make sure that the person obviously isn't missing doses. Leaving cues for attention, so as I said, not leaving really complex instructions. Permanent reminder notes I think are really helpful. Things in the kitchen, creating just a list that says, these are the phone numbers to call if there's an emergency, or remember to turn off the coffee machine. All these sorts of things can actually be really helpful, and I think that they are helpful for us as well as patients. Leaving things in the same place, I think, is also sort of an extension of that. And any to-do lists or reminders, make sure that you go out and walk for 30 minutes every day. That kind of stuff can actually be really helpful. And these are all sort of simple things that one can do. And again, keeping things consistent and organized. Writing down the sequences or steps that might be related to a task if there is something that's a little more complex. Making sure to schedule social activities, which are very much encouraged. People need to be social. We are social creatures by nature. We need to interact with people. A big red flag is that if people start to withdraw, if people start to say that they don't want to, either because they're embarrassed about their symptoms, or that they just feel that they don't want to interact with people as much, they're going to do worse. I can just tell you that right now, that people need to interact with other people, and they need to do it on a regular basis. And anybody who is starting to withdraw more and more needs to be evaluated pretty quickly, but they also need to be encouraged to continue to be social. And again, avoiding multitasking or just overloading with choices. Some of the other things, again, writing down emergency contacts, making sure that it's in a location that's always seen, that's always known. Possibly using a medical bracelet, making sure not to finish the sentences of a person who's talking, either because you want to hurry the conversation along, but actually just making sure to give the person the space to express themselves completely, and trying to avoid sarcasm in practicing patients. These are just things that obviously, it's not this person's fault that they have Parkinson's, and if the conversation takes a little longer, or something takes a little longer, we all need to be more patient, I think, in our lives, to make sure that the person is allowed the full range of expression, and that they don't feel shunted to the side because they can't keep up necessarily with the conversation at the pace that we all have. So these are all pretty small. So some of the other things, offering help only when asked, and again, following up with that is making sure to really encourage independence with the person. Prompting, saying, instead of, oh, did anyone call, say, oh, did Linda call? Just kind of giving that memory cue as well. Saying the name of the person when you're talking to them, making eye contact, and making sure that they actually have your attention. Again, keeping things in routine places, medications. This is an instance for our new generation, using photos on a cell phone to sort of prompt the face name association. So, we all become a little harder to remember names and all that kind of thing, but actually seeing someone's face does help. And all these things are just sort of helpful prompts that one can do throughout the day. And I think that there is a lot of validation that can come about by someone who maybe chronically has trouble with names, to encourage all these sorts of little things, because then when they're like, oh yeah, that's Susie, then that's a good moment for the person to be like, hey, great, I actually, I'm 1 for 20 today with names, but then maybe tomorrow I'll be 2 for 20. When a person's searching for a word, trying to provide a cue, such as maybe the word you're looking for starts with a D, presenting a list of actions and then talking and then writing them down, so sort of this, two-form kind of thing. Asking questions to moderate conversations, so trying to be more inclusive when having a conversation maybe in a bigger group to make sure that the person continues to be involved in the conversation. I think a lot of people with Parkinson's, especially in big groups, tend to sort of be listeners, and that's good for them from a social point of view, but it's not great as far as an interactive point of view, and it really is important to make sure that you try to encourage and moderate the conversation so that the person can share and can be involved. Keeping track of the changes that you notice, that's sort of a dangerous one, because more importantly, everyone should be trying to live their lives as normally as possible, and we don't normally sit around writing down every single change that we see throughout the day. It's also a little dangerous because if you go looking for things, you're going to find them eventually. And we don't really need any more issues to deal with than we're already dealing with. We should be able to deal with the things that come our way, but we shouldn't go out of our way to find other issues. So maybe making a document if you know that there is a follow-up appointment with a neurologist coming up, where there's a couple of things that you want to make sure that get addressed or get brought up, and of course the follow-up visit. But every day chronicling everything or every change that you may or may not have noticed. A, you're going to drive yourself crazy. B, you're going to be thinking about Parkinson's even more than you already probably are thinking about Parkinson's. And, you're also going to make the person kind of self-conscious about the fact that they probably feel a bit like a lab rat that's sitting there being documented. And again, seeking medical attention for any changes that are sudden. As we talk about more of like an advanced cognitive impairment, so there are strategies, there's something called therapeutic fibbing, which is basically just trying to ground someone who is in distress, who is experiencing, who has dementia, and it's sort of just playing along or going along with conversations that may not make the most sense or may not be going in necessarily the straightest of directions, but they aren't harming anyone either. And if a person needs to feel as though they are given the chance to express themselves, and maybe what they are expressing is not necessarily the most coherent, going along with it can be okay. Again, the decision making, so telling, not asking, so being more directive rather than asking for a choice or giving a choice, but just saying this is what we're going to do, or I need you to do this right now. Not relying on discussions, verbal or written reminders, so when people get to this point, just sort of the idea that, you're not going to be able to say, oh, I told you about that yesterday, did you do it? Because it's possible that the person's not going to remember that conversation, and even if you've written it down, maybe that they didn't see it, or maybe they've gotten to the point that they don't necessarily always check the area that the daily list is being kept. So just making sure that, for you guys, that all the big safety concerns have been taken care of, so getting to that point that you're shutting the coffee machine off, before you leave the house, rather than asking the person to do it. And the most important is accepting help, both early and often. So being able to, when you're offered help, to accept it before it becomes necessary, but know that you have people around you that can help you. And knowing that you getting a break, may encourage the person with Parkinson's and actually maybe reduce some of the feelings of burden that you're feeling. And again, these are for people who are much more sort of into the advanced dementia. So I'll touch for a moment on Parkinson's disease and psychosis. So as Sarah mentioned, that we do have the Parkinson's Outcome Project run by the foundation, which is following several thousand patients. That what people are saying, there's about 20% of patients at some point during their disease are experiencing some form of hallucination. And about 70% of people who have had it for more than 20 years are most likely experiencing hallucinations. That just is given the fact that Parkinson's is such a long-range disease, and we know that, again, it's affecting other portions of the brain, and the longer that we live with something, the more opportunity, unfortunately, it has to affect other domains. The one thing I would say with this, though, with regards to the hallucinations, is that, anyone who takes too much anti-Parkinson's medication, like Sinemet, really runs the risk of also experiencing hallucinations. That's one of the side effects of it. So I don't know exactly when they pulled this information, whether they counted into that the people who were reporting hallucinations that were related to medications versus hallucinations related to actual disease progression. Again, overloading with dopamine is basically one of the most common and reversible ways. And as we talked about, as people get older, they do experience the effects of medication much differently. But that psychosis can also just be related to the advancing disease and any changes. Possible treatments of rebalancing the dopamine, so either spreading out the medications, so that they aren't getting as much at any one given time. But if they're taking 6 pills a day at 2-3 times a day, that maybe it's more important for them to take them 5 a day and start cutting them up, something like that. That there are atypical antipsychotics. This is probably one of the bigger problems because antipsychotics are basically reduce the level of dopamine in the body. And a person with Parkinson's already is experiencing reduction in dopamine and is taking possibly therapeutic, dopamine like Sinemet. So you basically run into taking 2 medications that are in a constant battle with each other. I think that sort of thing really has to be regulated very carefully. There are newer antipsychotics, which they call the atypicals, which are less likely to produce, the symptoms. So anybody taking an antipsychotic can actually start to experience Parkinsonian symptoms, and that's because their dopamine levels are dropping. So they can very much present as someone who has very classic Parkinson's. You take away that drug and you wait about a year sometimes and all those symptoms can actually go away. But if you are someone with Parkinson's who's on dopamine medication and then possibly the need for antipsychotics, you're really running into a lot of problems as far as medications battling each other. And then there is Neuroplasticity, which is the new drug that came out a couple of years ago, which is specific for Parkinson's-related hallucinations and those sorts of things. They have that awful commercial, which every time that I talk to the rep, I say, can we get a new commercial now? And they're like, yeah, we tell them, we always give them the feedback, and they say, well, it's starting the conversation. It's like, yeah, but the conversation it's started, A, and B, it's scaring a lot of people unnecessarily, it looks like a horror movie trailer, and you shouldn't be presenting a drug in that way. So I'm bringing it up every time that I talk to the Neuroplasticity people, but it is available and does seem to help people. So some of the ways that people might experience, hallucinations, as I said, so sensing, hearing, smelling things that aren't actually there. Illusions, so misinterpreting something that is real. This can be seen a lot at night, so a coat hanging on the back of a door becomes a person standing in the corner, that sort of thing. And then delusions, which are just more, the sort of irrational views or persistent, thoughts that aren't actually based in reality. The other thing I would say is, a thing that a lot of people experience that isn't quite a hallucination, but it's the thought of a presence, that people will often report that they think that their spouse is standing just behind them, and then they'll turn around and they won't actually be there. So it's not quite a hallucination. They're not seeing their spouse in a place where they aren't actually at, but there is this feeling of someone or something being near them, but then when they turn to look, they aren't actually there. So I think I have heard that more often than I have heard people saying, I saw a cat running across the bedroom and we don't have a cat. So what do we do if someone is experiencing hallucinations? So obviously the first thing is you want to talk with the doctor. It's important to stay calm and patient with the person. Increasing lighting. So this is probably the best thing to do if someone is experiencing sort of a frank hallucination. So in the moment, what you want to do is you want to turn all the lights on. It's going to combat any sort of illusionary aspects, so the person will see that that is actually a coat hanging on the door and not a person. But also just increasing lighting in general just feels, it grounds people, and sometimes that can be all they really need to get through sort of the acute aspect of a hallucination. You want to talk to the person about the experience, and if they have insight, you want to obviously just sort of press the idea that the person, that the hallucination is not real. If they don't lack insight or they don't have understanding, you don't want to argue, you don't want to challenge the person, obviously, because that's just going to create more anxiety in an already sort of anxious situation. And you just basically want to do what we talked about, sort of like therapeutic fitting, and just kind of going along with it, and just knowing that it's not obviously something that's going to be long lasting, but you just want to kind of get through it. And then trying to educate anybody else that's going to be around the patient if this is a person who's experiencing a lot of hallucinations, and just make sure that they understand and have sort of these same ideas in place if they are around the person. So delusions and confusion, again, you just want to talk to the doctor first and foremost, calm and patient. You want to make sure dangerous objects, obviously, are not around. So if that means taking guns out of the house, that's what it means. As well as making sure that kitchen knives and things like that are not around. Arranging furniture in a way so that people don't trip and fall. So it's really important for sort of an occupational therapist to evaluate a home for home safety. It's something that can be done. Throw rugs is sort of the number one thing. So anybody that has rugs, loose rugs in their house, I know they're nice, but get rid of them. They're a terrible tripping hazard. Even if you have the corners locked down, even if you have, although it's still just, it's a gamble that you don't want to mess with. Putting night lights in the house, especially sort of to the bathroom and back, but throughout the house is probably even better. That just is a way of reducing any tripping. It also, for people who wake up, who might be experiencing maybe sort of an illusionary thing, that having that clear space, you get out of a nice warm bed, you're still half asleep, and being able to just sort of follow those lights in a safety way is actually really good. So not arguing or challenging the person, and again, just educating others who might be around the person as well. If this is someone who is experiencing this every once in a while, you don't necessarily want to make that the biggest deal, but just having somebody understand, okay, this is going to be an aspect of it. So just to sort of sum up for this, so cognitive changes definitely can occur in Parkinson's. They also can occur just for all of us as we age. Physical and social activity, I cannot stress that enough, that it is both physical exercise as well as the social activity. That more than anything would really, really help people both to stave off cognitive changes and also to slow, hopefully, any progression. Having regular follow-up visits with a movement disorder specialist, so that is a neurologist who is actually trained in movement disorders like Parkinson's. It's really important, if at all possible, to make sure that you're seeing those people because they understand the drugs, they understand the symptoms, they understand the follow-up better than maybe a general neurologist is going to. Investigation for any reversible causes that we talked about. And then appropriate evaluations by any sort of mental health specialist if the issues are starting to become more frank. The home safety evaluations, as I said, so making sure maybe that there are grab bars in the bathrooms, that there aren't any sort of just unnecessarily unsafe conditions in the house, banisters for stairs, those sorts of things. Making sure to monitor Parkinson's medications, because one of the most common things for cognitive change is obviously the medications have been taken maybe too often or too close together. And then just, trying to practice patience, which is, I think, something that all of us really should do more of.
How do you do that?